Hello, this is Cameron Sabat, and I'm here today with Dr. William Eward. He's the Residency Program Director at Duke and an orthopedic oncologist. So, nice to meet.
Thanks for having me, Cameron. Hello to everyone on the pod.
Thank you so much, and welcome to Cutting to the Case. So, I had a couple questions because your path is truly singular. So, you're both a physician and a veterinarian, and now you are leading comparative oncology efforts at Duke. And, can you walk us through the key inflection points that led you from vet school to orthopedic oncology?
Well, Cameron, I never really thought of it as making a shift. I went to vet school after college because that was my dream. I'd always thought I would be just a small town vet back where I grew up. And then I was surprised in vet school that I got really interested in orthopedics and really interested in sarcoma. And so I'm probably the only person who went to med school to become an orthopedic oncologist.
Wow. So that's a very singular, very specialized path. That's quite laudable. Thank you very much for sharing. And this comparative oncology, I was reading about your research. It's a radical frontier. So what are the most compelling insights you've uncovered by studying sarcomas across species, and how might they change how we treat musculoskeletal cancer in humans?
Well, so many people do consider it radical, but it's probably an error on our part that we view it that way. It was actually Rudolf Virchow who in the 19th century said we should be doing this, that we should be studying animals to learn about humans. And we somehow adopted the part of it that says, yeah, let's make mouse models of disease, but we failed the part of it that says, let's look at naturally occurring cancers when they're not in humans. Mm-hmm. So the problem we have in sarcoma, as you probably know, and as your listeners probably know, is that they're rare. Mm-hmm. Well, they're rare in humans. They're actually not rare in dogs. And so when we study sarcoma in dogs, it opens up our world of knowledge to much greater numbers of patients.
Wow, that's incredible. And I'd spent many of my high school years doing murine models in Dr. Karen Eisinger's lab at UPenn on undifferentiated pleomorphic sarcomas, cool. Actually. So I did a lot of this work, and that's kind of what drew me to interviewing you. So you lead high-stakes surgical care and direct a research lab. How do you balance these complex operative cases and the translational science and the leadership across institutions? And furthermore, what's your system for staying focused?
Well, first of all, I'd really encourage you or anyone listening to consider an academic career. It really is a lot of fun. It's so rewarding. If we weren't training the next generation of people, and if we weren't tackling complex problems, we would just be stuck practicing the same kind of medicine we do today. But I think you used the word balance, and the balance really is the key. Mm-hmm. I don't really strive to have a work-life balance per se, a work-life balance. I strive to have everything make sense. And that just means that part of your week has to be about research, part of your week has to be about education, part of your week has to be about these surgeries, and then of course, the most important part of your week has to be your family. And it changes week to week. But I think what you have to do is always make sure that you have the right balance.
Absolutely. And I actually recall Jeff Bezos had talked about this as well at Davos or one of these economic forums. He said, work-life balance is more like, additionally, it's over the years. And so some years you may spend more in training and other things, and some years you may spend more with family. And so I really appreciate those insights you have on balance. So kind of to move forward, you were recently appointed Residency Program Director at Duke. How are you thinking about orthopedic education in 2025 and beyond? And what cultural values do you want to instill in the next generation of surgeons?
Well, I really appreciate that question. It's a huge honor to take over this role. Mm-hmm. The Duke Orthopaedic Residency, it's really a unique place. You'll often hear people say the culture is very unique. You'll often hear people describe it like a family. And a lot of that goes back to Dr. Bill "The Rock" Hardiker, who was a legendary program director at Duke and was the program director when I was a resident there. And really what we try to do, this sounds corny, but I mean this very literally, is that we really try to have the program be centered on love. We really try to bring in people that have a lot of passion, have a lot of humility, have a lot of compassion, like to learn, like to teach. And we try to use those traits as the basis of truly operating like a family or maybe a small sports team where everyone loves each other, everyone relies on one another, everyone can trust one another, and that just makes it fun.
Absolutely, yeah. And you really appear to extend that kind of culture of compassion and love to your patients as well. And so, many of these patients are facing devastating diagnoses. And how do you approach those conversations about goals of care? And how has treating animals changed your view of what compassion looks like in medicine?
Those are great questions, Cameron, and I may break them apart. People often expect orthopedic oncology to be sad, even other orthopedic surgeons, and the secret truth is that it's not sad. You didn't give those people this problem they have. You're simply the person helping them out of it. And one of the things I enjoy about the job is trying to talk to each patient about what bothers them the most and what their goals are. Maybe it's to be out of pain. Maybe it's to do a specific physical activity. Sometimes it's actually to look normal, either for personal or cultural reasons. And as you go through the process of, instead of saying each sarcoma gets treated this way, figuring out what each patient wants and needs and trying to give them that, and the bonds are incredibly rich.
Yeah, absolutely. And thank you for sharing that as well. And that really extends to these questions of equity as well in surgical care. When you make these patient bonds, you're really, forging these connections with community partners, essentially. And so I am curious, equity in surgical care means something different in oncology. And how can, you as a leader in orthopedics, but additionally academic systems, what can they do better for patients with rare cancers, especially those even outside those major care centers?
Well, I actually think that the academic centers do it really well, Cameron. I think the challenge is more for how can we have private practice type enterprises do this well. I'm grateful every day that in the academic environment at Duke, I'm just paid a salary. And it's very easy for us to take somebody who either is Medicare, Medicaid, or doesn't have money for their care at all, and for us just to say, we're a big university, we'll figure it out. My bosses would probably hate that I'm saying that right now. But I love the fact that we're able to just treat people right and not worry about the money. But for many private groups trying to do this, that's just not practical. So I think the real challenge is, how do we figure out how to make complex care for patients with something lethal that need equity of access to care? How do we make that financially solvent?
Absolutely. Yeah. No, that's a really important point. All the questions about finance and all of those other issues. What are your thoughts now on the emerging value-based care model in orthopedics? With, I believe Medicare came out with one last summer for hip and knee. What are your thoughts on that in oncology?
Well, the short answer is I don't love it in oncology. And one of the things we deal with in oncology is that it's really the antithesis of a hip or a knee replacement. Where the problem, if you look at, say, osteoarthritis, that's a very uniform problem with a very uniform solution by the time you get to the arthroplasty stage. Oncology is the opposite of that. Every tumor is a little different. Sometimes, even going into the surgeries, we don't know what the magnitude of that surgery is going to be, right? And so it really makes bundled care difficult. And I don't love the way that there is sort of some momentum to try to lump everything into these care models. For instance, if I'm posting a proximal femur replacement, that gets posted as a hip replacement because that's the closest thing in the complex world of coding and billing. And a distal femur replacement is posted as a hinged knee replacement. And that starts a snowball effect of trying to pigeonhole that patient and their needs into the model of a hip or knee replacement when, as you know, resecting a tumor from someone's proximal femur or distal femur and then reconstructing it is just very different.
Yeah, it's just too complex to fit into that simple mold. Even with the risk adjustments, it's just too much to be able. Each cancer is truly unique. So.
That's right.
Well, speaking of those, outcomes and complications, your team has published widely on these surgical outcomes and complications and surgical readmissions. From your vantage point, what clinical questions remain urgently unanswered in your field?
I think the biggest clinical question, which spans oncology, arthroplasty, almost every field of orthopedics, is the problem of metal implant infections. The people who solve that problem will deliver an incredible gift to the medical world and to millions of patients around the world. We still struggle with the fact that when a metal implant gets infected, there's no blood supply. The antibiotics you put in the bloodstream can keep that infection from spreading, but they can't cure it. And we're still left with explanting people's hardware to effect a cure. So to me, that's the single biggest thing.
Even more than heterotophic ossification or any of those?
Well, you and I could come up with a long list of important problems that need to be tackled, like HO. And it depends on our expertise, right? I mean, I've just said that I think metal implant infection is the most important problem to be solved. That's not what I work on because that's not where my expertise and passion lies. At the end of the day, people will do their best work if they go where their passion is. My passion is for trying to make improvements in care of sarcoma patients.
Yeah.
And that's why I do what I do.
Yeah, that's fantastic, and thank you so much for sharing your insights there. So you've also, and if you don't mind me being a little bit more personal, you've shared your son's journey in orthopedics and his rowing success. How has being on the patient family side shaped the way you relate to your own patients today?
Cameron, I'll tell you, every time either someone in my family has had surgery or I've had surgery, it has made me a better doctor, hands down. And I'll give you sort of a big picture, small picture answer. So my middle child, my son Luke, who's 19, he's a very good rower, and his athletic career was almost derailed by labral tears in his hips. And a surgeon, Dr. Chad Mather, literally saved my son's athletic career. So it's just neat seeing the power of orthopedic surgery on a very personal level. And then everything that happens, you get these little tips. For my son, it was this simple cooling device, which doesn't require ice packs or putting ice into a machine. And sorry, company, I'm blanking on the name of it. I'll try to think of it before the end of the episode. But once I saw how much that helped him, I now order that or something similar for all of my patients.
Wow, that's incredible. So yeah, as we're nearing the end of this episode, as we do have a 15-minute limit, orthopedic oncology, it doesn't seem like it's a job. It seems more like a calling. I wanted to get your perspectives on that. Like, what's the one enduring lesson you've taken from this field that shaped how you live your life outside this operating room?
Oh gosh, that's a great question, and I completely agree that it's really not a job. It is a calling, and my family jokes that if I didn't have this as my job, I would somehow have it as my hobby. It's the relationships that just make it so rewarding, that somebody lays down on the operating table with cancer and they wake up without cancer.
Yeah.
But what it's really done for my life is this appreciation of our mortality and how precious life is. And it just makes you get every hug you can from your kids, appreciate your own health and your own body, and just really drink life in.
Wow, that really makes life richer.
I'm really grateful to my patients for giving me that perspective, and they reinforce it every week.
Yeah, and it really shows that you care about every single patient. I really appreciate it. Thank you very much for coming to Cutting to the Case. And
It's been a pleasure.
yeah, of course. And thank you. This is Cameron Savitt, and we're signing off. Bye.